Good evening, everybody. Thank you for staying back. And it's such an honor and a privilege to introduce Professor Carlos Pavesio from Moorfields Eye Hospital, London. So to talk about, he's like consultant ophthalmic surgeon for the medical retina service at Moorfields Eye Hospital, London. He was the medical retina service director between the years 2008 and 2016. He's an honorary clinical lecturer and uveitis theme leader for the Biomedical Research Centre, Institute of Ophthalmology, London. He's also an honorary consultant ophthalmologist at St. Thomas' Hospital in London. He's a member of many international ophthalmological societies, including International Ocular Inflammation Society, International Uveitis Study Group, American Academy of Ophthalmology, and also a board member for SOE and European Union of Professors of Ophthalmology. He's an organizer of the uveitis program from Retinal and SOE for more than 10 years. He's also an organizer for the international uveitis courses, both in UK and abroad. He's given more than 300 lectures, both in UK and internationally. Dr. Pavesio is also a professor of ophthalmology in New Zealand in 2009. He was also a visiting expert in ophthalmology, uveitis, intraocular inflammation, medical retina in Singapore in 2014. He's also a faculty member for the Cole Eye Institute uveitis courses held annually in Cleveland, USA. Besides this, he's an editor-in-chief for Journal of Ophthalmic Inflammation and Infection. He's a member of the editorial board on British Journal of Ophthalmology, Ocular Immunology and Inflammation, International Ophthalmology, Journal of Ocular Infections and Inflammation, and Ophthalmology. And he's authored more than 10 book chapters and over 150 peer-reviewed publications in the field. So this is when I was an observer with him in 2016 after finishing his OR. And these are some of the lighter moments from yesterday when we went for a trip to Mahabalipuram. He looks pretty happy and engrossed. You can see here as he's clicking pictures from all the sculptures. And these are today we had some discussions in the clinic with cases and in the lab. And we all welcome you from the uveitis services, Shankar Netralaya. Welcome, Dr. Pavesio.
Thank you very much. It's for this amazing welcome and this very humbling introduction. I'm very honored to be here. It's my second time in India. First time was in Chandigarh only, so this is my first time down here. And it's a real privilege to visit such an amazing institution. And thank you for your time this morning, Dr. Vistas, for showing me around and introducing me to your colleagues. An amazing department, group, and fantastic work. I've been following your publications and your group, so it's really great to be here. And great to be introduced to the Indian cuisine from the south, because in the UK we only eat from the north. So when I go back, I'll find a restaurant that specializes in southern Indian food, because I really enjoyed it. Need to find a place there when I can carry on enjoying it. So thank you again, and I hope my comments were helpful today. Tough cases. You just it is humbling because it shows me that after 30 years doing this, I still don't know a lot. So I have a lot to learn, and coming here is adding to my experience, and clearly all these cases will be in my mind, and now if I see something similar, I will think about this day and all the cases you show me, and how many times I told you I don't know. So it's part of the process of learning. What I'm trying to do within this half an hour that we have is just talk to you about local therapies in uveitis, which is something that is being evolving. It's an area where we are seeing more developments, and you can understand why. All these drugs we've been using all these years are so toxic, and the patients don't tolerate, dislike the drugs, have so many side effects, and finding better alternatives local level is helpful. The real purist immunologists are very much against this, because they think uveitis is a systemic problem. The cells in the eye are not generated in the eye, they're coming from the general body. So why are you treating the eye only? You have to treat the whole body. And it makes sense, for us, in my mind as a clinician, for the patients, if I tell them you have a disease affecting all of you, and your eye is part of it, it makes sense to treat everything. But when they come to you and they have an eye disease, example typical is birdshot, and they say, why am I having to take all these poisons to treat something that is only affecting my eye? And if I cannot treat everything, if I can prevent the damage to the eye, I'm already achieving a benefit to the patient. So that's the rationale for local therapy. So this is my financial disclosures. Okay, so I'm connected to these companies for research purposes. So we know very well all this. We've seen today huge examples of the challenges that we have, starting from knowing what's causing the problem, the diagnosis. Now, we have a lot of challenges there, and many times we really don't know what we're dealing with. So the bulk of our knowledge is that's exclude infections, that exclude a neoplastic process, then we are left with immune-mediated diseases. That's when you then start using all the weapons you have to control damage to the eye. So these are the issues that, in terms of the limited options, the management, of course, we are improving. You know, when I started practicing, the limited options were very limited, really. We have a bunch of drugs we could use, nothing else. Today we have more options. The biologics are coming in. New biologics are released and tried, and all these local therapies I'm going to talk to you about now. The real point to stress here is this issue of the visual loss in uveitis is driven predominantly by macular edema. And this is a real challenge to treat macular edema, as you well know. The eye is full of barriers, so it's not easy to get drugs into the eye. Every time you put a drop in the eye, the drop doesn't get in very easily. You try to give injections and all that. The drug has to go through barriers to get into the eye. So there are many barriers from the systemic point of view as well that are preventing high levels of the drug achieving good concentrations into the eye. So these are the approaches that we use locally. Topical, of course, we all know anterior uveitis is the best way of treating that. But once the inflammation is predominantly posterior, the drops that we have at the moment become not very good. I'm saying at the moment because I know in the pipeline there are new drops coming around. The Americans have been using a drop I don't have in the UK called Durezol, difluprednate. So that's a drug they claim treats posterior disease. I don't have it, so I don't know. I don't have a personal experience to tell you about that. But there are drops in the pipeline that will allow better penetration of the molecules into the eye and hopefully achieving higher concentrations that will allow easy use topically. But by far, at the moment, that's not available yet. So these are the options we have locally. We have the periocular injections, which have been around for a long time, especially the subcutaneous injections. You have the intraocular injections that can be given, especially intravitreally. And of course, we have the devices that can be used to treat the eye. That's we're going to try to cover all that. This is something I learned, and these slides actually are from the place where I trained, which is the Proctor Foundation. This is Dr. Nozick, who created this technique of posterior subcutaneous injection. So you try to put the steroid right behind the posterior pole of the eye, achieving high concentration to treat macular edema. Of course, you have the orbital floor injections, which you can give, are safer to deliver, probably achieve good levels in the eye as well. And studies comparing the two are very few and indicate a trend towards better outcome in the posterior subcutaneous comparing to the orbital floor injections when it comes to macular edema. But both are used and variable results. I would say the chance of improvement with these injections is about 50-50. So it's a bit of a, you try more than once, of course, if it fails. This is the difference here between having what is a orbital floor in which the injection goes outside the cone and has to disperse everywhere, and putting it right behind, which is the posterior subcutaneous treatment, which gives you probably a better chance. So these are some studies that have been comparing the use here of the periocular triamcinolone acetonide injection for cystoid macular edema complicating infectious uveitis. This is a paper that was done by Jennifer Thorne, and essentially you can see here is the level of response that you achieve. She's claiming like an 80% response in the first month, and then you have the need to re-inject some of those patients after a certain time. But you can see the level of recurrence is quite high. That we come back, as you expect, most of the injections we give around the eye or inside the eye, they will last for a certain time, and then you have to go back and reconsider injecting the patients again. You know very well that for a long time we've been using this Canalog, which is completely off license. The medications you can see in the box talks about intraarticular and intramuscular injection. It's not intraocular injection. I think we can get away If a lawyer knocks on your door because a patient is complaining that he put an injection in the orbit and there was a problem and you use an off-license medication, you can say the socket is a joint. There are tendons, muscles, so you can say that potentially the socket is a joint, and you can claim that the intra-articular injection is okay. But when it goes into the eye, it's a different story. Then you have no excuse. So the Americans have, I put it here to show you that people were at one point in time, not sure if you did that yourselves here, but people were trying to achieve a higher concentration of the drug into the eye. If you take 0.1 of ml of this vial here, a mixed vial, it gives you 4 milligrams, right? But if you want to do more, what do you have to do? Well, you turn the vial upside down, or you suck into your needle upside down and put it on the wall and wait, and you can just suck the crystals. And then you have a higher concentration. You don't really know how much you get. People claim, oh, 20 milligrams, 25 milligrams. God knows. We don't know. We know it's never calculated properly. But then you give this very large concentration into the eye. That's what it looks like when you put into the eye a blob. Just a blob of stuff in the eye. And that will gradually release the drug over time. And will have a very beneficial effect. It works very rapidly. So it does achieve concentrations that are very high. It bypasses the barriers, so there's no more barrier. I'm already putting the drug inside the eye. And it will be very efficacious, but short-lived. And there's an issue of toxicity. So the Americans have triessence. I'm not sure if you have triessence here. It's extremely expensive. It's just as expensive as the Nosradax is today. So we, in the UK, have still been using triamcinolone when we need it. There is now an intracenol. There's a new formulation which is preservative-free, and it can replace the triamcinolone. So it's the same IVTA that we've been doing. But again, the issue is you need to repeat injections, and that's a problem. The reason why triamcinolone was chosen, I'm just putting it here to show you, because dexamethasone, which is what you can use in your toxoplasma local therapy with clindamycin combined, will last a very short time inside the eye. But if you're using triamcinolone because it's hydrophobic, it's going to stay in the eye a lot longer. This is a non-vitrectomized eye. Vitrectomized eyes, it's going to wash out a lot faster. So this is it will not last 3 months. It's going to be a lot shorter than that. This is the original work showing the mechanism of action of the triamcinolone in the eye, how long it stays, the pharmacokinetics of the drug, and it showed that one injection would last you about 3 months in an unvitrectomized eye. This is how quickly it works. It will really get rid of the effect of edema in a very short time. So my personal, this is the range again I'm telling you about before, the concentration of this a bit more, and this is the licensed product against the unlicensed product. So this is what the Americans have against this. And we now have this intracenol as an alternative. The interesting thing, I only put this paper here because it's the only paper I found is an animal model in rabbits looking at the potential effect of the preservative and all the other potential toxic things in the triamcinolone injection. And in the rabbit model, it showed no evidence of toxicity to the retina, both in function and histology. So the concern that you have about injecting, it's going to be toxic to the retinal dot, at least in an animal model, it doesn't prove to be the case. It seems to be safe to use. And I think, how long have you been injecting IVTA? For a very long time. And I think we have enough there to show that it's not causing toxicity to the retina, predominantly safe to use. Even though, of course, we all have seen the endophthalmitis, the sterile endophthalmitis that can happen as a consequence of this reaction, maybe to the crystals. And that's a potential problem. And we see that more in uveitis than in other diseases. So this is something that is the important distinction here. Macular edema can happen in the setting of an active uveitis, or macular edema can happen after the uveitis is controlled. And that is the chronic edema that you don't see the inflammation active at the same time. So when you have active inflammation, you suppose, and you want to see that controlling the inflammation will lead to resolution of the edema. Well, when the inflammation is already controlled, then you're stuck with edema that may not respond very well to your approach. So this is one alternative, and it's being explored. There are other ways of trying that. But this paper, this is from a colleague in Austria, who you may not know, Professor Barisani Atzenbauer, showing that it does seem to help. So what I normally do for IVTAs, I use them only in 3 scenarios. One is a top-up if someone has been treated systemically and presents with an acute macular threat, like a Behçet's patient who walks in with a macular threat. I can top up the systemic therapy with an injection in the eye to protect the macula. The second scenario, I have a chronic edema, and I want to know if vision will improve. Because sometimes you keep adding drugs, treating, and the edema is there and the vision is poor, and you're just hitting your head against a brick wall. You need to know if the edema resolving will improve vision. So give one injection in the eye, resolve the edema, measure the vision. If the vision doesn't get better, you know it's not going to get better, so you can then reconsider your strategy. And the third scenario is if I'm doing a cataract operation on someone I couldn't control very well before. Normally, I would want to control for 3 months at least before I operate on the eye. But there's a reason, intumescent cataract, I cannot control the patient, I have to operate faster. Then at the end of the operation, I put an intravitreal triamcinolone into the eye as an acute protection, so I couldn't prepare the patient in my usual way. These are the complications. Every time you put a needle in the eye, there are some complications related to putting the needle in the eye, and then a second group of complications related to what you're injecting in the eye. So some of these are needle-related, some of these are drug-related. And very common, you know very well, cataract and glaucoma. These are the main complications from steroid use inside the eye. And IVTA has a high risk of that happening, especially if you are repeating them. Drug delivery systems, why were they created? Well, I'm just telling you now that I inject something into the eye, it will last for a short time, and then it disappears, and I have to inject again. In my mind, and that's a general thinking I have, I want to see inflammation controlled steadily. I don't want to see inflammation going up and down. So I control, and then it comes back, then I react again, I inject again. So the inflammation is bouncing all over the place, and these patients don't really control long term. I want to see something that allows my inflammation to go down and remain down long term. So the rationale for a long-acting device in the eye is that it gives you a constant level throughout a long period of time. So that will protect the eye from recurrences, protect the eye from the cumulative damage of recurrences, and consequently allow barriers to reestablish, allow the eye to go back to a more normal system. The first of these devices that was approved, and it's been licensed only in the US by the FDA, is not licensed in Europe, so we don't have the Reticert. I was involved in the Reticert trial, and unfortunately the EMA did not approve it. But we know that it was supposed to deliver the medication over a 3-year period of time, delivering a concentration about 0.3 to 0.4 micrograms a day. So the device itself had nearly 0.6 micrograms of the drug, not milligrams of the drug, but it was releasing 0.3 to 0.4 micrograms a day. So this is what it looks like, very small, and this is what it looks like when inserted into the eye. Okay, so this is sutured to the eye wall, pars plana incision, suturing the device so it doesn't fall into the eye, and then you close the sclera. And that's supposed to be there for 3 years. In the beginning, we were suturing with nylon, which was a mistake, because nylon, what does nylon do? It disappears over time, and they will drop into the eye. So that was the experience with the gun cyclovir that we learned, and then we didn't use nylon here because we knew it's going to be dropping into the eye. And then we change the suture. You want something that's going to last a long time. So the Reticert, there were studies in the US and studies in Europe that were done. In the US, they compare different concentrations. In Europe, we use only against standard of care. And essentially what it showed, and I'm going to show you this here, it was significantly protective of the eye in terms of a recurrence of inflammation. It really reduced the risk of developing a recurrence comparing to standard of care. So that was a very positive outcome. It showed good in terms of recurrence. The 3-year rate of recurrence was much lower. If we look at the frequency change between before and after, it was significantly protective. So the positive effect was markedly positive. That was the basis for the FDA approval. Okay? What was the basis for the EMA refusal to approve before more studies were done? Is the frequency of side effects was very high. You can see here, in our study, it was about 30% patients needing filtering procedure because of pressure problems. That was a real problem that the EMA didn't like. The American study was even higher, it was nearly 40%. The other thing was cataract. Cataract really, after a certain time, is nearly 100% of the patients develop a cataract. From my point of view, if I had to argue with the EMA, I would say that cataract and pressure are very common problems in uveitis anyway. But if I can achieve better quality of life for my patients, controlling the uveitis well, I'm happy to deal with these complications, sort them out, and continue with the control of the disease. That's not the view they took, and they refused to approve that. So in summary, this device did improve the recurrence rate significantly. It did help to stabilize or improve visual acuity in the patients. It was associated with significant problems with pressure and cataract occurring. Very common issues, as I said before. The MUST trial is a study multi-center uveitis steroid treatment trial. This is being taken forward. This is done by, it is sponsored by the NEI, and John Kempen is being the lead clinician behind these studies here, but many American colleagues and some people in the UK and Europe have been involved. And it was just looking at the long-term benefit of this. And it's interesting that, if you look at this study, the MUST studies here, I think I have to show you the data from the 7-year. I'm just going to mention this very briefly here. But when you look at the MUST data that was recently published, if you've seen the publication, it's talking about the 7-year follow-up. And that 7-year follow-up data is saying that after 7 years, the patients receiving standard of care, systemic therapy, did better than the patients who had implants in their eye, right? But the data they acknowledge, the follow-ups were they lost a lot of people to follow up, and the data that you look at is not clean. So I think that conclusion is flawed. I don't think we can actually believe that that is a paper that can be trusted to tell you, ignore this local therapies because systemic therapy is the way to go. I'm just going to skip here. This is the 7-year paper I'm telling you about now. So this paper speaks in favor of standard of care instead of local therapy for controlling. You're all familiar with Ozurdex. We've all injected Ozurdex. Ozurdex came in and being used for nearly everything now that we can treat edema from diabetic macular edema, vein occlusion-related macular edema, and is licensed for use in uveitis, not only macular edema, for treatment of uveitis. The Huron study, amazingly enough, Allergan managed to approve a drug with the FDA, 1 trial, 6 months follow-up. Data from 6 months was enough to approve this drug. So that's surprising. The FDA doesn't normally do that, but it did this time. So the trial was comparing a sham injection with 2 different concentrations of the Ozurdex. And this is what a randomization 1:1:1, and those patients then were followed up over a period of time, over 4 scheduled visits, 8 weeks. So it was a 6-month study, essentially, that we saw. And it showed, which is the primary outcome measure, was vitreous haze of 0. It did show a benefit of both the 350 and 700 in comparison to the sham, which was significant. So they achieved the primary outcome measure of their study. And it showed significant in terms of vision as well. Both of them achieved the same. At the end of the day, they found that the 700 was achieving, the color code is completely wrong, so don't look at that. But the significant benefit of the 700, the one that is commercially available, is 700. And it is better because it's more efficacious and it did not increase the risk of side effects. So it was adopted as the drug to be used. It showed, of course, this is very limited data from 6 months follow-up. So the pressure issue was never found in this study. It's too short to find that. And cataract also is too short. We found problems in cataract way after, months and months after the injection was given. Okay, so this is what I said. So it is an available option. We have been using because it's licensed, so it makes more sense to do something licensed against an unlicensed product, but it has the limitation of the duration of the effect. The experience in the UK is that the effect in uveitis is lasting about, the average is 4.5 months. So it's not lasting the 6 months that they said it's going to last. It's less than that. Some patients go a bit longer, some go a bit less, but 4.5 months is the average time. So it means you have to inject them probably 3 times a year to achieve that control. And again, I don't like the idea of seeing escape of control before I react to inject again, because I'm going backwards in the control of the disease. So I have concerns about that problem. So this is a patient, it was a paper published by Uwe Plyer, a colleague from Berlin, talking about the use of dexamethasone in real world, so only in his center And what he's saying at the bottom here, he's saying about the repeated injection of that the dexamethasone for the treatment of non-infectious uveitis, alone or in combination with other treatments, improved the situation, and he didn't feel there was a real problem with complications. They were reversible, managed locally, an exception of cataract surgery, which needs surgery for. So he's claiming that, yes, this is a good alternative, this is what we've been using in the real world, and it works. I would agree that it's effective, it does work, but it doesn't last, and that's my concern. So this, I think, is another one talking about the use of this for cystoid macular edema and quiescent uveitis, and it does show also a benefit in many patients receiving this implant and having regression of macular edema even when the uveitis has been controlled. You've heard of this device, right? This is available and licensed for the use in diabetic macular edema, and last week received approval by the FDA under the name of UTIC. Is not Iluvien. Iluvien is what is used for diabetic cases from Alimera Sciences. UTIC is coming from another company, American company, but it is essentially the same implant. It just comes with another name and another injector, but it's the same thing. So it was approved by the FDA on the basis of the data of the 24 months study. We know the data now of the 36-month study. I'm not allowed to disclose it because it's still a company secret. I'm an advisor to the company, but I'm bound to my contract with them, so I cannot tell you that. But essentially, FDA has approved it for the use in uveitis. And essentially, the beauty of this is that it's one injection through a 25-gauge needle. So Ozurdex is about 22 to 23 gauge, so you have to tunnel into the eye. This one, you go straight in. It doesn't leak when you finish the procedure, and it's very easy. The patients feel comfortable receiving it, and it will release the drug over 36 months. And so far, what we know from data from other centers as well is that it seems to last the distance, it goes the distance. And it keeps a concentration of the drug pretty much at a good level throughout the time. So this is the study that we've been involved in. So this is the Sevita study, the company that produced this, and it shows the comparison between fluocinolone and a sham injection. The randomization was 2 to 1, wasn't 1 to 1, so we had more patients receiving the implant, and the patients were followed up over 36 months, collecting data about the efficacy and side effects throughout this period of time. And it showed very well. This is the data the data for a limited. Well, this is 12 months results. This is not the full study. As I said, the data is not ready to be released. But it's showing in terms of days how much better the implant is in terms of preventing recurrence of the uveitis, of controlling the disease in the eye, is significantly better than the group receiving the sham. You can look here at the median time to have a recurrence. It's over 378 days for the implant against 70 days for the sham group, so significantly better. In terms of recurrence rates, what you see here, unfortunately, when this slide was saved, is changed a bit of the formatting of the slide. But it shows very clearly that the recurrence, known recurrence, is significantly better, the green, comparing the two pie charts here in the sham and that. Recurrences which appear in white and yellow, these are observed recurrences and imputed recurrences. Imputed recurrences mean something happened that the patient was either not followed up to the end or something happened in the treatment during the course of treatment which was breaching the protocol, and the patient had to be considered as recurrences because the data would support that something was wrong, and most of the patients had imputed reasons for that being based on the use of drugs they should not have used. Some of them were missing data. But it shows that even if you just disregard the imputed ones, it's significantly better the use on the implant eyes than the sham eyes. In terms of vision, you can see here that you might find it interesting that while a lot of the patients, even in the sham group, maintained reasonable levels of vision, but the patients regaining vision were the patients more on the implanted arm of the study. Why is it so similar? Why is it not hugely different? Because there was rescue therapy. So a lot of rescue therapy was used in the sham arm group. So that's why there was some degree of protection. That's why the data is not that different. Okay? Safety issues, of course, if you compare sham to the fluocinolone, you see that there were pressure problems and cataract problems much more in the group receiving the steroid, which is expected. But the level of this is significantly lower than the Retisert. So it's a step forward. when it comes to that. So this is a summary of what I just told you. So the results are showing that this is a good alternative for control. The data so far is supportive of that. It does achieve control, leads to less complications than what the register did, and it is waiting now, of course, for the publication of the 36 months data. So we'll have then the final stage. But the approval by the FDA is already telling you this is likely to become a choice that we can use. The only problem is the cost. The cost is going to be high. But they're charging and thinking this is going to last 3 years. So you spread that cost for 3 years, and you see it's cheaper than the Ozurdex. That's what they're doing, okay? This is very briefly now, we're going towards the final stretches just to show you a few other things. This is another attempt to treat locally using a non-steroid option, which is sirolimus, which interferes with the proliferation of cells, and it leads to block of release of interleukin-2. So recruitment of cells is going to be reduced. And the idea is to put this into the eye, and that will last about 2 months. The trial, the Sakura study, the Sakura studies were exactly comparing these different concentrations of this drug, and the primary endpoint again was vitreous haze, because that's what the FDA likes to see. And they were looking at vitreous haze of 0 and then secondary outcome 0.5. And what you see here, this is the design of the study. So there were 3 arms, patients receiving 44 micrograms, which was considered an active control. So there's no sham in this study, no placebo effect. There was a 44 microgram comparing to 440 and 880 micrograms, given every 2 months. The primary endpoint was measured at 5 months. But then the patients were allowed to continue with the injection every 2 months, but they were all receiving the 880 instead of the other options, okay? This study completed, reached its endpoint, and what was interesting here is that when this was done, they concluded that the 880 was not the best alternative for the treatment. The best alternative was the 440. The results were supporting that 440 was better. But for their bad luck, the 44 also produced an effect. So when they compared to their control, the results were not terribly different. So when the FDA looked at the whole data, the FDA said, you're not proving that you achieve your control. The first study did. The second study didn't. And the FDA did not approve it. So this has been temporarily shelved. I'm not sure what Suntan, the company behind it, will do. But clearly they had a setback. First study, great. They have to do 2 studies. The second study, same protocol, did not reach the same. If you combine the data from the 2 studies, it's positive. FDA did not accept that, which is a shame, because this is a good non-steroidal alternative. It did work very well in many patients, but you did not achieve what they expected. So at the moment, not going forward. I just want to show you, because it's something that you will hear about. This is showing the primary endpoint. There was significant difference in the group receiving the 440, even more when you look at the secondary outcome measure, which was 0.5 vitreous haze. So it was significant, but they were this is the first study. The second study did not achieve the same result, okay? In terms of vision, you find that the problem with vision is that if patients had good vision to start with, there's little room for improvement. You don't get a lot of benefit. The patients who had worse vision at the beginning were the ones where the difference was more obvious. They got improvement. But the ones that started very good, well, how much better can you get? That's the problem. So you end up finding there's not a significant difference here. So, yeah, there's a problem with them is that we're finding this unmet need of finding a different alternative. The study showed to be positive. The Sakura study won, and it was a very interesting and promising study, but it didn't complete what we expected. Just a very brief mention. We talked about VEGF in one of the cases we discussed today. So VEGF has a role? Yes, probably. In uveitis, there will be an expression of VEGF. It was found to be highest in patients with macular edema in the anterior chamber. So blocking VEGF may help you. But the message I want to leave with you is that VEGF can be used for macular edema, for choroidal vascular membrane, and people are looking even at retinal nevascularization. Can you use it? I say I would support the use in patients who are this refractory macular edema, eventually may respond to that approach, especially patients who are steroid responders with high pressure in the eye to steroids. This could be an alternative to help them. The problem you have, you know very well, because you use this to treat your AMD patients is that the effect disappears and you have to be re-injecting them on a regular basis. So not practical, not a very good way of doing that. So it's a problem for macular edema. For CNV is a different story. In CNV, it might very well be an alternative. The point I want to make for both CMO and CNV is before I talked about it, control the inflammation. Do not replace your treatment of the inflammation with an anti-VEGF approach. The anti-VEGF is an adjunct treatment to help you control, but it's not your main objective. It's not going to control the problem if you don't control the inflammation, okay? So don't forget that. You can use, yes, but treat the inflammation, control the inflammation well. So these are just cases to talk about the choroidal neovascular membrane, which is achieved. So again, control the inflammation well. Very briefly, final slides now. This is new. It's not happening yet. We are involved in the study, designing this. This is gene therapy. This is gene therapy not using a vector. It's putting the plasmid into the ciliary muscle and making the ciliary muscle produce anti-TNF therapy inside the eye. So rather than injecting the drug into the eye, you're injecting the plasmid and making the eye manufacture the anti-TNF for you. So this is the idea, is making Humira inside the eye, okay? So its essence is that you inject and you put it in the eye. It will then, from here, release the drug inside the vitreous cavity. And it will be the duration of the effect. At the moment, we're still in the middle of the study, so beginning the studies now. We don't have all the data, but it seems to last at least for 2 months, maybe more. And we need to figure out how we're going to do that. So that's how you do the injection, put it in there, and then you transfer using electricity, make it move inside the ciliary body, and then you produce the antibodies there, the drug inside the eye. I'm going to skip this here. That's the current, and then you make the drug inside the eye. So this is something we are involved. This is a French company, and we are in the middle of developing this. Finally, suprachoroidal injections. Is the Peachtree study is looked into the benefit in vein occlusions and macular edema. It did not show any benefit in relation to anti-VEGF therapy. So from the point of view of macular edema, and vein occlusion is not going to be used. But you are involved in the study. Manta is involved in the uveitis study for this, and we're waiting for data to see how beneficial it is. I think it's another alternative, not very invasive. It's very easy. The needle is very small. It goes into the right place. You put a steroid, and it may become an option for the treatment of choroidal inflammation or macular edema. We'll see what the study will show. But this is what we are waiting. So there are a few things in the pipeline to add to our alternatives, and there are other things we already have with their limitations, but moving forward. So these are the conclusions. So we do have available options that are effective. There are more things coming on the way, and the trials that are ongoing, and hopefully giving longer duration and going beyond steroids. So replacing steroids with something else that is going to avoid all the side effects of the steroids. Thank you very much. I think the problem with any local treatment is going to be concentration and duration of what you put into the eye. And even in viral infections, when we're treating these days, you can give the intravitreal antiviral foscarnet, which is the drug we use, but you know that in aggressive disease, you may have to do twice-a-week injections initially before you control the disease and you achieve that control. My concern with TB, for instance, because it's a lot of the times choroidal pathology, is to achieve levels inside the eye which are going to be good enough to penetrate through to the choroid and treat the disease there. Most of the injections were like the disease you mentioned, toxo is a retinitis, viral is a retinitis. When it comes to choroiditis, that bothers me because my experience at the moment, I have used the Iluvien to treat birdshot. Birdshot is a dual pathology disease, retina and choroid involved at the same time. I put the Iluvien into the eye, the retinal vascular disease controls beautifully well. I look at the choroid, not at all. Is not touching the choroid. So what's happening is, even though the concentration achieved inside the eye is good to treat retinal vascular disease, it's not good enough to reach the choroid. So this is one of the problems. The RPE is a big barrier for movement of drugs through to the other side. If the pathology is choroidal predominantly, we'll have trouble achieving good concentrations to treat. So in choroidal pathology, I'm still in favor of systemic therapy being your best option for levels to be reached at high levels to be maintained. So I think that might be one of the limitations in TB, as you're mentioning there. TB, usually you don't get a retinitis in TB. You end up getting an inner choroidal or choroidal, and you have trouble with your concentration of the drug in the eye. I think that might be one of the limitations that we have. But yeah, I have hope that we're evolving. We're doing more things than we could do before. So the clindamycin yes.
It works better if toxicity.
Well, yes. The point with the injection for toxo is the clindamycin, the data we have from many studies that have been done show it's equally effective to systemic therapy. The data show that combining clindamycin with the dexamethasone reach similar results to giving systemic therapy, okay? The point is how many injections you need to give. And you look at the studies, it's a variable number. It goes from giving 1 to giving 5, maybe 3 average injections necessary to control an episode. So in terms of efficacy, from the point of view of what we have the experience, it's showing that they seem to work equally well. You would favor, okay, well, André has published his paper recently now about the frequency of side effects to systemic therapy in toxo. And it's a lot more than we suspect. He's showing like 80%. 80% of his patients had side effects to oral medication used for toxo. So if you think about that, you would favor local therapy. You say, why am I going to put a patient through that? If it's the same outcome, I'm going to put a needle in the eye and do the injection, which is reasonable. If that's what you want to do, you can do because the data supports that. What happens is many times not practical. It may not be easy in a clinic to do that, or you're concerned about creating an infection or creating a hemorrhage or a retinal detachment or whatever. But at the end of the day, you could very well argue in favor of local therapy against systemic therapy because the efficacy is good, and we know that. What I worry is more if the disease is further down. That's what I worry. I think in this case, if you want to do it, I don't have a problem with that. The biologic, the intravitreal biologic is the Ivensis study. That's going to be an intravitreal biologic. But the advantage here is that you are making the eye produce the biologic for you by genetic engineering, rather than injecting the drug into the eye. There have been papers published about the use of it local. Yeah. And on the basis of the results of this study, that the company got excited about using because they seem to work. But again, it's a question of, no, I have never done it, so I don't know. How long is going to last the effect? How frequently you have to inject? How easy it is to prepare the injection? That's what I don't know either. So these are questions. I have never done it. I've read papers in which people have done it, and they report. So that's exactly the positive response to this approach is what convinced these guys that it should work if you make it locally. Okay? No, not regular. If I inject a periocular steroid, I would do it at least 2 weeks before the operation because I need to reach concentrations in the eye that are not going to be immediate. It takes at least 2 weeks to get a good level in the eye. Normally, my patients are prepared with systemic steroids for surgery. If I cannot do that for any reason, medical reasons, the patients cannot do that, I tend to use an intravitreal steroid at the end of the case. I inject it at the end of the operation. That's what I normally do. For what, sorry, for? Yeah. No. No, even if I couldn't prepare, only if I could not prepare the patients to use. You could ask why. Why don't you inject everyone?
There are some people who are
Yeah. Yeah. I think it is a reasonable approach. I think eventually it will become the standard to do it, especially when you have a licensed option. Remember, Ozurdex is not that fast. Ozurdex takes 2 weeks also to reach an effect. So if you finish your operation and put the Ozurdex in the eye for 2 weeks, there's no protection. So it's not a good alternative. The IVTA is different. IVTA is immediately effective. So if you want to do that, inject, you have to use an injectable liquid preparation. And if you have a licensed product, which now we will have, and that's what might change at Moorfields, because we've been reluctant to use Kenalog for all these patients, right? But with this intracenol, we may be able to do that and become the standard of care, which now is an option licensed and sterile and not full of other things inside.
So that we don't have to give.
Yeah, if you do that injection, you probably can get away with that. But still, you need those 3 months of really good control before you plan the operation, and then you can use it. I think the results are going to be good. I think it's going to be likely to be fine. Yeah.
local therapy? Local therapy for that?
Okay, that's a good question. So it's absolutely, the thinking is, the ideal treatment is for unilateral or asymmetric disease. This is the ideal scenario, okay? That's when local therapy is the best option. Bilateral disease doesn't tell you can't do it, but it becomes harder to be proposing bilateral injections and all that, unless you have a long-acting device that will last 3 years. If that works, then you inject the eye, one eye, inject the other eye, and for 3 years you don't have to worry about it, okay? I wouldn't worry about this, okay, doing bilateral. What I don't like is the idea of bringing the patients back every few months and having to inject both eyes. Then I would favor systemic therapy for that. Remember, if there is a systemic underlying disease, systemic therapy, no doubt. There's no question about that. The local therapy is a top-up. If your systemic is failing and you're threatened, vision is threatened, I use a topical local as a top-up. But for a standard for a systemic disease is systemic therapy. Bilateral disease, probably systemic therapy also preferred. Okay?
And I would be concerned about the side effects.
Yeah.
So like both eyes, you end up with
Yeah, you have to discuss that with the patient. You have to explain to the patient. And now you'll be surprised how many patients are very happy to run those risks because they don't want to take the tablets. And the fluocinolone implant, this one, not the Retisert, okay? Remember, the Retisert also had fluocinolone. It's the same drug. Essentially, the difference is two things are different. One is the dose that is released into the eye over time is much lower. Is a third of what the other one released. Second point, that implant was sutured right at the front of the eye. So the implant was very close to the front of the eye. So probably the concentration in the anterior chamber was very high. This implant we put right at the back. So the concentration in the anterior chamber is very low. That's the main reason why there's such a big gap between glaucoma in the Retisert and glaucoma in the Illuvian. Because there is a different release rate, different location. So you end up with a much lower risk. The risk will be there. You have to tell your patient, you may need filtering procedure to control your pressure. This is what is involved. And many patients understanding that will be saying, I'm happy to run those risks. I'm happy to go through this because I cannot tolerate the side effects of the tablets I take. It's an evolving area. It's going to change. Patients are, depending on each patient. Some patients may say, no, I don't want to have anything in my eye that will complicate. Fair enough. Go and have systemic therapy. Okay? Yeah.
One last question here.
Yeah, there's one more here. Yeah, yeah. So the question is methotrexate locally for unilateral disease and all that. I don't use it. Okay, I don't use it. I think the data from there was one study from Moorfields actually that came out talking about this. I have concerns about that data, and if I speak to my colleagues who are uveitis experts in the field, nobody's using that. Nobody's convinced that local methotrexate controls uveitis. Okay, so I don't use it, and I don't know many people who use it. I think it's been an explorative study, showed some good results, but at the end of the day, didn't convince most of us that it was a good option. So I don't do it, and I really cannot say much more about that. I have no personal experience. I know what you know from what you read. Well, but only steroids, only using steroids. Well, if you have a bilateral macular edema, which is recurring, appearing when you're lowering the steroid, I'll think of a second-line agent. I'll think of immunosuppression. I think what you'll find is that periocular injections will not control long-term. So what's going to happen in 3 months' time, you have edema again, 4 months' time. Then you have to inject again. So you have to balance all that. I think if you can achieve a low dose of immunosuppressive combined therapy that controls the edema, I would favor that in this situation rather than injecting. I think in what will change the game, intermediate uveitis, I think of birdshot as an intermediate uveitis plus choroidal pathology because it behaves in a similar way. My idea of an implant lasting 3 years to treat the vascular component of the retina, if that is proven to be the case, which at the moment is my experience, it seems to work very well, you may end up treating your intermediate uveitis with that approach because it will control the disease very well without any systemic therapy. So that eventually will become the future of these patients. As birdshot, the future may be an intravitreal Illuvian and a suprachoroidal because one treats the retina, the other one may treat the choroid. Eventually your suprachoroidal will treat everything. If that's the case, wonderful. I don't know the data because I'm not doing the study, and you are, but we don't know the data yet. Eventually it will become. But the other option is combining the two. that might work very well. So things are evolving. We're all learning. Thank you again. Thank you for the invitation, for this wonderful reception, and great to be here. Thank you.
Thank you, sir. Comment right back, we have a group photo.
On behalf of the uveitis service of Shankar Netralaya, it's an honor to thank Dr. Carlos Pavesio and Dr. Andre Curie for having visited us in Chennai, spending the day with us. Thank you for all the lovely discussions that we had through the day on various cases. We hope you enjoyed your stay and your visit to the Mahabalipuram and hospital. Thank you, sir. Thanks to Professor Rajkumari from RIU GOH for having taken time out to come for this meeting. Thank you, ma'am. Thanks to all the delegates, the multimedia and housekeeping for helping us with this CME. Thank you all.